Welcome to Pharmacology Mini number 10, where we'll talk about mood stabilizers. Mood stabilizers aim to stabilize mood in patients with bipolar disorder, so it helps to lower the highs and raise the lows. Categories of mood stabilizers include anticonvulsant medications, as well as lithium. And then other medications that we can use adjunctively for bipolar disorder include antipsychotics, anxiolytics, and antidepressants. Lithium is our golden line therapy for bipolar disorder, and it tends to be effective in about 60 to 70% of patients. It is a salt derivative that produces a serotonin receptor blockade and increases neuronal growth as well as decreases neuronal atrophy. Side effects of lithium is that it can cause GI distress, hand tremors, polyuria. So if they do need a diuretic, it needs to be a potassium sparing diuretic like spironolactone. It can cause weight gain and renal toxicity, so we would want to get baseline kidney function. It can cause a goiter and hypothyroidism, so we'd want a baseline T3, T4, and TSH. It can cause arrhythmias, in particular bradycardia. It can cause hypotension, electrolyte imbalances, and lithium toxicity, which we'll talk about. It is a pregnancy category D. It is contraindicated with diuretics, NSAIDs, or anticholinergic medications. We would want to use it in caution with those that have renal disease, heart disease, low sodium levels, dehydration, in older adults, those with thyroid disease, seizure disorders, and diabetes. Nursing considerations is that they do require plasma lab monitoring because lithium has a very narrow therapeutic index. So when first starting the dose, they'll get lab draws about 1 to 2 times a week, then that'll progress to monthly, and then every 2 to 3 months. We would also want to get lab monitoring with any dose changes. The therapeutic level for bipolar maintenance would be a lithium level of 0.6 to 1.2, and for acute mania, it would be 1 to 1.5. As with psychotic disorders, we do see that with bipolar disorders, medication compliance can be an issue, especially in individuals that experience mania because they like the feeling of mania. So we would also want to educate our patients on medication compliance and use that as a nursing consideration. Lithium toxicity is due to lithium having that narrow therapeutic index. So like I said, a therapeutic dose is about 0.6 to 1.2. Once we get to about 1.5 to 2.0, we start seeing fine tremors, cogwheel rigidity, GI disturbances, polyuria, polydipsia, agitation, confusion, delirium, and they may develop kind of a metallic taste in their mouth. When it's at this level, we would want to withhold the dose and notify our provider. From about 2.0 to 2.5, we start seeing coarse tremors of the limbs, muscle weakness, muscle twitching, hyperreflexia, slurred speech, blurred vision and nystagmus, ataxia, sedation, lethargy, and hyperthermia. At this point, we're providing them with an emetic or a gastric lavage, and we can also provide them with urea, mannitol, and aminophyllene. If it becomes greater than 2.5, we consider that severe toxicity, and we'll see coarse tremors of limbs, delirium, stupor, seizures, QT interval prolongation, renal failure, respiratory complications, coma, and death. So when this develops, we would need to provide hemodialysis for the patient. Then we have our mood stabilizing anti-epileptic medications or anticonvulsant medications. The purpose of these medications is to potentiate GABA, inhibit glutamic acid or glutamate, and suppress CNS excitation. Examples of this include carbamazepine, or called Tegretol, valproic acid, also called Depakote, lamotrigine, also called Lamictal, oxycarbamazepine, also called Trileptal, and topiramate, also called Topamax. Side effects of carbamazepine include nystagmus, double vision, vertigo, staggering gait, headache, leukopenia, anemia, thrombocytopenia, teratogenesis, edema, decreased urine output, hypertension, dermatitis, Stevens-Johnson syndrome, and hepatotoxicity. For Lamictal, we can see blurred vision, dizziness, headache, nausea, vomiting, and Stevens-Johnson syndrome, which is a medical emergency that we'll talk about. Then we have valproic acid, which can cause nausea and vomiting, indigestion, hepatotoxicity, pancreatitis, thrombocytopenia, teratogenesis, and weight gain. Interactions and contraindications for carbamazepine include that it's pregnancy risk category D. It can cause bone marrow suppression and bleeding disorders. The therapeutic range for measurement would be 4 to 12 micrograms per ml, and they do have to get that monitored frequently. It does decrease effectiveness of oral contraceptives and warfarin, so we would want to educate our patients if they are taking oral contraceptives that they may need a second form of birth control. When taken with grapefruit juice, it can lead to toxicity, and phenytonin and phenobarbital can make this medication less effective. Lamictal is pregnancy category C. It interacts with carbamazepine, phenytoin, and phenobarbital, which makes it less effective. Valproic acid increases its half-life, which could lead to toxicity, and this also decreases effectiveness of oral contraceptives. Valproic acid, or Depakote, is pregnancy risk category D. It is contraindicated in patients with liver failure. The therapeutic range is 50 to 120 micrograms per ml, and it should not be taken with phenytonin and phenobarbital because that can lead to toxicity and increased levels. So now Stevens-Johnson syndrome, which can be a side effect for many anticonvulsant medications. This is a medical emergency that starts off with flu-like symptoms, so a fever, fatigue, and burning of the eyes. Then a rash develops on the skin, and this rash can be red or purple, and it oftentimes can blister. Then the individual will start developing severe skin pain and breakdown of connective tissue. So the skin tissue will start to break down and will lose layers of their skin as it's shed. It can also cause damage to mucous membranes, so they may develop a sore mouth and throat as well. As far as treatment for Stevens-Johnson syndrome goes, we would want to remove the cause, do fluid replacement, especially as they lose layers of their skin. They're going to have a harder time with water retention, so they're going to experience a lot of water loss and dehydration. We would want to provide any wound care and eye care that's needed, pain management. We would want to provide them with any anti-inflammatory agents, either topically or by mouth. We could provide them with antibiotics, IV steroids, IV immunoglobulins, and oral medications that we can use are cyclosporin and Enbrel. And that wraps up our discussion on mood stabilizing medications.